Okie doke. So, what we're going to do today is start by going through a history. And I'm going to ask you a series of specific questions that will get me up to speed with the details of what's going on with your foot and ankle. And that'll kind of lead us into an exam. And we'll go through a series of movement tests and things that will help lead us to the right diagnosis and therefore treatment plan. So, we are looking at your right foot and ankle today. So the first thing that we want to get established is to map out the symptoms that we're evaluating today. So where are the symptoms that we're talking about?
Are on the front of my foot and the side up the back here.
Okay. And is this pain, ache, numbness, tingling?
This is kind of like stiff in the front and then burning up the back here.
Okay. No numbness or tingling?
No numbness or tingling. Yeah, and it does ache at the end of the night.
Okay. All right. No symptoms that go above?
Nope.
Okay. Any back pain?
No.
Okay. And this has been going on how long?
2.5 years now.
2.5 years. And when did it start? From injury?
Correct.
What was the injury?
A sprained ankle.
Sprained ankle.
Correct.
How'd that happen?
Walking and I tripped and had a lateral ankle sprain.
Yeah. Okay.
Yeah. Had to be in a boot for about 6 weeks and then weaned out of the boot, was non-weight bearing in the boot, and then weaned out of the boot into a brace for 4 weeks and then tried to rehab it, and it just has not gotten better.
So there was never a point in the 2.5 years where you got better?
It's gotten slightly better.
But not resolution?
No resolution.
It's been a consistent issue?
Correct.
Ever since that happened?
Yes.
To some degree?
Yep.
Okay. Now, are those symptoms felt every minute of the day you feel that, or does it come and go during the day?
So if I'm like off of it, well, right now it's kind of hurting, but like for the most part, if I'm off of it, it's not bothering me as much as if like I'm up and moving around, it's hurting a little bit more. But the biggest part is like I can sleep all night and be fine, and I can wake up and I can go to the bathroom and get ready and it's fine, and then it just like
gets worse as the day goes on. Okay.
Yep.
Is it pain-free in the morning?
Pain-free in the morning. Completely pain-free.
Okay.
Yep. It does feel stiff though, like super stiff in the morning.
Okay. And so you are, typical day, working, you're on your feet.
Correct. Walking throughout my day, standing, squatting, stepping.
Yeah.
That kind of stuff.
Days off?
1 day off a week. I work, and I'm due off on Saturday and Sunday.
And what do you like? Is that a day where you're still on your feet the same amount?
About maybe about half the time, because I have my own business, so I'll sit and sew a lot, or I'll get up and run errands and stuff. So it just depends. Or we'll have like a lot of doctor's appointments. I'll be in the car and up and downstairs.
But the more time you spend on your feet, the worse it feels.
Correct.
Yeah. Okay. Gotcha. And then you're able to get to sleep at night, and you can sleep through the night. You wake up, it's a lot better. It's not hurting. And that pattern is consistent. Mornings are always better.
It's been consistent lately. Yes. Yeah. For the last couple of months. It hadn't been. It was like I had to ice it to go to bed, and then.
So the past 2 months have been better than.
Yeah.
And do you know why that is? Is there a reason for that?
No.
Okay.
I don't actually know.
So past couple months seems like it's been improved. It's a consistent pattern that it's following. Now, when you are on your feet, moving around, walking, doing things, are there specific movements or activities that cause immediate increase in pain when you do it?
Pushing down my foot like this, and then like if I'm stepping up onto a step can be very painful, or like pushing, like bending my foot and bringing my other foot down from a stair.
Okay. All right. Anything else that stands out just day to day?
Hard to stand on one foot.
Okay.
Hard to do single leg heel raises. Like those are nearly impossible on that right foot.
Mm-hmm.
I've tried to get over just to one leg heel raises and just can barely get 2 or 3 in before it just cannot handle it.
Mm-hmm. Okay. And then activities outside of work, recreational things, or anything that you've had to stop doing that you're trying to get back to doing that you
I'd
can't
like to
now?
get back to more exercise and gym-based exercise and stuff, and
Mm-hmm.
it's been limiting
Okay.
those exercises.
Okay. All right. And I'm assuming you had an X-ray after you sprained the
Correct.
ankle, and they didn't
X-ray,
find any.
MRI. So the
Oh, you had an
MRI,
MRI as well.
yeah. So the X-ray didn't show anything, but then when they did an MRI, they did show a slight tear of the peroneal tendon, and then they showed a avulsion, but they weren't quite clear on how old the avulsion was, whether it was just recent or if it was something that's been there for a little while.
Okay. And have you had any treatment? Physical therapy, cortisone?
Yes, I've had cortisone in physical
You
therapy.
did, and
Mm-hmm. The
nothing.
cortisone was awful,
Okay.
and then that actually made it so I couldn't walk on it for over a week. So painful. And then the physical therapy just didn't seem to help at all. Like I tried to do all the things,
Mm-hmm.
I'm still trying to do the things, and
Didn't make it worse, just didn't really help.
it really makes it mad.
It did.
Really angry. Yeah.
So
the single leg work is really challenging.
So you were okay. So in terms of things you were doing, you're working on
a lot of balance, like eccentric squats, like single leg, split squats, lunges, things like that. Those are really, really challenging.
Mm-hmm.
Any single leg heel raises, double leg heel raises can be pretty painful. Like any plantar flexion with a band, that kind of stuff I was doing, leg press, squats.
Yeah, a lot of exercise, and it was just aggravating it.
Correct.
Okay. All right. Any other intervention?
No.
Okay.
Mm-mm.
And so, yeah, past couple of months, it's been some improvement. Otherwise, you feel like you are kind of stuck.
Correct.
Yeah.
Yeah, I'd like to move forward.
Yeah. Okay. Anything else that you can think of in terms of its pain behavior that we haven't addressed yet?
I don't think so. Pain is pretty constant except for at night, and then it does get harder throughout the day. That's pretty much it that I can think of.
Yeah. Okay. All right. Otherwise, generally healthy.
Yep. Very healthy.
Okay.
Very active.
Any significant past medical history? Rheumatoid arthritis?
Nope.
No other like medical conditions or things that you've been diagnosed with?
Nope.
Okay. All right. So 2.5 years ago, to recap, sprained your ankle while walking, and eventually had the MRI and X-ray showing peroneal tear, an avulsion fracture of some kind. Not sure how old that was. And now you're left with intermittent pain that is better in the morning. It can be intermittent, gone in the morning currently. Worse as the day goes on your feet, walking, squatting, steps, stairs, things like that. It gets progressively worse as the day goes on, does not disturb your sleep. And you want to get back to more gym exercise, leg exercise without pain. And the cortisone shot and physical therapy both have kind of been aggravating to the problem.
Correct.
Okay, so that's good. So now we'll just kind of shift gears a little bit, and we'll go into the exam portion and start looking at what we find in that department and see if we can make an answer to what is going on.
Okay.
All right, so step number 1 with the exam is we just want to take a look at the structure of the foot. Without it in weight bearing, we just want to look to see if there's any discoloration, if there's any swelling. And then if there's any suspicion of muscle atrophy or anything like that, then you might need to have the patient be in shorts to look at muscle bulk. But for purposes of this, we can kind of get an idea if there's any concern for muscle atrophy without having to do that. But if we need to, that would be a consideration. So first off, we just want to look at the foot and just see how does it compare to the other side. Again, with respect to just any potential areas of fluid. You can start to combine assessment items at the same time by, I can start palpating. I can start by lightly palpating to see if there's any allodynia, which, is there any?
Not really.
No. Mm-hmm. Okay. And then hyperalgesia, which is where I would actually start to apply. That's pretty tender.
Yeah, it's more tender on the ankle bone. Ouch.
So then we can start to see there's no allodynia, but as I'm doing my observation, I can also just do some of my palpatory assessment right there. Yeah. I might want to do more later, but now is that more on the bone?
Oh, yeah.
Okay. Mm-hmm. And then if I go up, any issue there? That's, yeah.
Not as painful, but yeah, it's
okay.
Yeah. Not so bad there.
Okay.
A little bit right there. Yeah.
So this is a good example of where the exam does not have to go in an exact order. So we can be as efficient as we want about it as long as we collect all the data. There are 10 steps in the exam, and we want to consider all 10 steps to get our answer. But those 10 steps can be moved around. So tender. That's really tender.
Yes.
Okay. So.
Oh, yeah.
And so I'm primarily looking at palpation and primarily looking not to diagnose a structure, but more about level of irritability is primarily what I'm after. After I finish my exam, if there's a particular structure or tissue that's implicated, we might go back to that structure and do a more detailed palpation of that. But for now, we just know that there's some hyperalgesia in some few different spots in the foot. Okay.
Ouch.
Yeah. So a lot of sensitivity there. Yeah. Okay. So once we've kind of looked at a non-weight bearing observation, then we would want to look at a weight bearing observation. So let's go ahead and get you on your feet. And then what we're looking at here, so this is where we can use the foot posture index. That can be a good observation tool to look at foot position. So we're looking at the arch and looking to see what the height of the arch looks like, to see what the distance is between the two feet. We're looking at from a posterior view. If you go ahead and turn around, face the other direction. Yeah. So if we were to look at the alignment of the foot, we are looking at calcaneal position. So we want to see, is the calcaneus everted, inverted, neutral? We want to look at the malleolar curve, where we're looking below and above the malleoli to see if there is a uniform symmetrical curve above and below, or do we see that it is curved below but not above, or vice versa. We want to look at the too many toes sign to see if I am able to see toes medially or laterally, and if so, how many. We want to look at the talus position so we can palpate and see how much of the talus is exposed, medial to lateral.
Want the other one?
And then we would compare this on both sides. So we're trying to see how much of that talus is exposed, and we're looking for symmetry right to left. If we find asymmetries. That's painful. Sorry.
That's
so we
right.
can. Okay. And we take these things and note them, but we don't necessarily make a diagnosis off of this information. We're just collecting information, and it may be relevant later. Okay. All right. So once we've looked at observation, we can now look at a functional test. So this is where you can decide if you want to move right into function or if you want to go into range of motion, strength, etc. So in this particular situation, we would probably look at some kind of a functional test. So I'm going to look at gait. And so I think we'll look at that next. So let's come out here, Katie. Let's just have you walk a little bit.
Still.
Yeah, perfect.
And we're going to go 2 sets of 10 on each of those here. Here we go. Let's alternate them, yeah. Because that kind of has to do with balance shifts.
Okay. Is this hurting right now as you walk?
Yes.
Yeah.
Yeah.
Okay.
Yeah. Touch right around here.
Okay, let's come back in here. All right. Now, if you turn towards me, are you able to do a body weight squat? And that produces pain.
Yeah, but it's more in the heel and here. But
Okay, so some of that pain that you're feeling is in your familiar location
yes.
when you're squatting.
Yeah.
Okay. And do it one more time. Tell me when you start to feel it.
Right there.
Right there.
Yep.
Okay. And come back up. All right. Now, if you were to so if you put your feet together, and if you pick up your left leg, so it's at about 90 degrees, and this produces pain.
Yes.
Okay. You can put your foot down. Same location.
Yes.
That produces your familiar
right
pain.
Here.
So you're capable of doing it.
Yes.
It just reproduces pain.
Correct.
Yeah. Okay. All right. Now, if you turn towards the wall, you could use the table lightly for balance. Let's start on the right side first. So if you were to do a heel raise, single leg heel raise, okay, that produces pain.
Correct.
Yeah. Same location.
Correct.
Okay.
Yep.
So we're looking to see, can she clear full range of motion? If it's really painful, then we may decide to, defer forcing full repetitions. 20 repetitions being a 5 out of 5 score. Just depends on how much pain is present. So this is something that you
I can really only do maybe 3 before it's too fatigued, but I can try.
That's fine.
It doesn't make it hurt worse when I do them.
It doesn't make it hurt worse.
Nope.
Okay. Let me see what you can do. Let me see how many repetitions you can do.
That's
Okay. And what's happening at this point?
It just feels like it just can't go anymore. Like it's
just losing strength.
Correct.
But not increasingly painful.
Nope. Same pain level.
Now we would want to check the other side just to make sure that this is unique to the pathological side. So let's go ahead and do some repetitions here. Okay. So all we need to know is that it's significantly different. And we would note that it was not painful, but was losing strength at around 5 repetitions, somewhere in that ballpark.
Correct.
Okay. All right. So again, you can see that this exam process can organically unfold however you want to. You don't have to go to active range of motion first. We can look at functional tests before that. It depends on the patient, but that's appropriate to do so. Okay. So now what I'm going to have you do, let's go ahead and take a seat on the table again. Okay, so I want you to resist me from pushing your foot this direction.
Okay.
I'll start light with the resistance. You tell me how it feels. If there's no pain, we're going to go a little more, a little more, a little more. Okay.
Mhm.
So go ahead and start pushing against me. Go, 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 go. How does that feel? More, 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 more. Nothing. Then I reach a 5 out of 5. I get a symptom response, which was negative. Now we'll do the opposite. Don't let me push that direction.
Okay.
Okay. We'll start light. Tell me how it feels. Push against me. Match my resistance. More, more.
Ah.
Okay. And
And
then
it just feels like it's going to let go.
feels like it's going to let go. Pain
Correct.
was
We're on this.
produced.
Yep.
So this is where I wasn't perceiving any weakness. I felt like I could have pushed more. Felt like she was matching my resistance. So I would need to document that something such as 4 out of 5 limited due to pain response versus an actual weakness that I could perceive. Okay, let's bring the foot kind of to neutral here. Don't let me push the foot down. Okay, same thing. I'll start light, go and hold, go, go, go. How does this feel? Go, go. Is there
Right
pain?
there.
Yeah. So same thing. We saw that I could break on that one, so I could call that a 4, but there's also pain produced.
Right in the same spot.
Yeah, right in the same area. Yeah, okay. All right, now, when we're looking at range of motion, we can check that with the knee bent, and we can check that with the knee straight, so we can look at muscle length versus taking 2 joint muscles out of the equation. So the position you do that in, we could do that sitting, we could do that supine. I prefer to do that in supine with a bolster, so it's easy to manage the leg and your goniometer and whatnot. So that's what we'll do next. All right, so you lay down on your back. So first I like to just observe the quality of the movement without using a goniometer, so I can just see how does it feel, how far does it go. So if you take both of your feet, pull them up towards you as far as you can go. Pull, 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 both sides, far as you can go. How does that feel?
It feels stiff, a little bit painful on this side, but not bad.
Okay. So the range of motion actively, we can measure this, but from a diagnostic perspective, which is the purpose of this video, is more of a diagnostic perspective. If I'm looking at the range of motion and it looks symmetrical, but it recreates a symptom, now I need to understand the end feel. I need to know if that truly is equal motion or if there is a stiffness. So I'm going to first get a feeling of normal. And there's pain there. So there's full motion, the end feel is normal, tissue stretch, but there is end range pain. Let's point both the feet as far as you can point, as far as you can point. And now we can see that there's clearly a limitation in mobility. Is that reproducing pain?
Correct, and it's really stiff across the top.
Really stiff across the top and some pain. Okay, let's relax. Okay, so now we need to know if that passive motion is equal to active motion, or if I can go further, then how does that feel? So if you just relax the foot, There's pain there. Okay. So now I want to know at this point, is that, ooh, okay. So now I'm trying to get a sense of an end field. Now I want to know, does pain correlate with an end field or is it an empty end field?
That was really painful, like right across the middle.
Okay.
And into the heel.
Okay. Okay. All right. So now let's take both feet, twist inward as far as you can. Twist, 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 twist. And how does that feel?
Stiff on this side. Fine on the other side. I feel like I have to like really lift me.
Yeah, so there is some loss. So again, we would measure the range of motion, but we're just wanting to get a sense of what that's like. So now I'm going to check the end feels. And tell me.
It's already painful.
That's already painful. Okay, tell me when pain increases.
Right there.
Right there. And if we go any further, what happens?
Feels a little bit better, kind of.
Okay, so that's where overpressure is important, because if we add more force and pain does not increase or pain decreases, we call that pain during movement, not end range pain. So when it comes to making a diagnosis, is that stiffness related pain, scarring, fibrosis, and things like that, we would say no, that would not be how that tissue would behave. So just to be clear and make sure that that is what I'm seeing, tell me when it starts.
Starts right there.
Okay, and then let's add more pressure. And what happens?
Stops.
It stops. So that is pain during movement, not end range pain. So when actively she inverts and it recreates a pain, there's a little bit of limited movement. Passively, it feels better, and I don't feel an abnormal end feel. I don't see a loss of motion. So now we've got a different type of problem on our hands. That particular movement, we can rule out a scarring fibrosis or capsular ligamentous type stiffness. So now let's roll the ankles out that direction, both sides. And tell me, how does that feel?
Just stiff on the right hand side, a little bit painful, but not much.
A little bit painful, not much. Now let's relax. So this is an active test, so the peroneals are actively working. There was a little bit of pain, so now I need to check this passively and take the peroneal tendons out of the equation. So totally relax the foot. And we'll evert. And what do you feel?
Right at that end range.
There's pain at the end range. Okay, stay relaxed again. I like to repeat the test a couple times to make sure there's pain there on the outside.
Correct.
So now we've got two clues that suggest the pain that is happening with inversion eversion does not appear soft tissue related, because when the peroneals are taken out of the equation, eversion is still causing pain out here. When I invert and I'm stretching the tissue, it feels better the more I move. So now we know we're not dealing with a soft tissue shortening, tightening, fibrotic type problem. That piece has been ruled out. And that's important because mechanism of injury and chronicity would suggest there might be some scarring and leftover tissue that is not working properly. But so far these tests would argue against that way of thinking. So now for inversion eversion, I can start to break up the different parts of the foot. So this is just global inversion eversion. But now I can stabilize the forefoot and ankle, and I can just move the subtalar joint and see how does that feel. So first I'm going to squeeze to stabilize. I'm going to ask how it feels to make sure that I'm not getting confused as I move the calcaneus if there's pain. Is there any pain with me squeezing like this? No. Now I'm going to squeeze the calcaneus. And there's pain there.
Yes.
Okay. Pain go away when I stop squeezing?
No.
No. Where are you feeling that?
On the outside.
Your usual spot. Okay.
Yep. Now it's gone.
Now it's okay. I'm going to squeeze the forefoot and ankle again. Is that okay? Now I'm going to try to just push on the medial aspect of the calcaneus to try to create motion in the calcaneus without squeezing the lateral aspect. So now I'm trying to evert the calcaneus. Is there any pain?
A little bit, but not bad.
And I'm
Kinda
looking for
actually felt good.
symmetry. And that feels similar. Okay. Now I'm going to try to invert the calcaneus, which might be challenging if it's as tender to pressure. I'll do the best I can to... How does that feel?
Painful.
It's painful. Now,
All the way through.
tell me about this. No pain?
No
So
pain.
I'm squeezing. I got to make sure that the pain is movement related, not squeezing related.
Ooh, yeah.
That's painful. So subtalar joint inversion is recreating pain. Now I can stabilize the subtalar joint and I can invert the forefoot, midfoot.
A little bit right there. Right there. Right at the end. Just a...
Okay. No pain
Not
there?
really, huh? Just a little bit, but not like very slight. Right
Okay.
at the end when you pull.
Okay.
Very tender.
Very tender to push on. So we have a lot of non-specific tenderness. We've kind of ruled out tissue stretch of these structures here. So now from a passive accessory standpoint, we can look at the talocrural joint. Again, we can look more at the subtalar joint. We can look at the midfoot and the forefoot and start to try to isolate the different articulations of the foot to see. The one challenge that we will see with that going forward is we know that there's a lot of just tenderness, global tenderness to palpation. And so these tests might be more relevant if we just look for quantity of movement, meaning is there any hypomobility or hypermobility? Is there any excessive movement? But in terms of a pain response, we may not have accuracy if there's just non-specific tenderness around the foot. So we might look at it just from a mobility standpoint, but the value of those tests might reduce just based on the non-specific tenderness to palpation. So we're going to shift gears, and I'm going to take this out from underneath you. Okay, now you'll stay there.
Okay.
Ooh. So on this side, if we do a straight leg raise, was nerve tension testing done?
No.
No. So if you just relax this leg, this foot, yeah, and then I'm going to raise the leg up. Tell me how this feels.
Just stretch.
Just stretching. Tell me when.
Big stretch. Yeah, right there.
Where?
Right here.
Okay. Nothing in the calf or foot or anything like that?
Nope.
Okay. Then I can add dorsiflexion. I'm checking the painless side first so I can get a good baseline of what to expect of normal.
Ooh, big stretch.
Big stretch. Where?
In the calf.
In the calf.
Correct.
And that goes away?
Nope.
Still big stretch?
Not big, but yeah, goes away.
Okay. So, all right, so we can just repeat the same test. tell me what you feel. I'm going to try to get my
You're
hand
fine.
in a way that is not going to give me false information here. Does that feel okay the way I have your?
Mhm.
Yeah.
Just stretch.
Just stretch.
Mhm.
Okay. I'm going to add dorsiflexion. Okay. How does that feel first off?
Just painful. It's fine though.
That's painful. Okay, let's relax. Okay. There's some pain there.
A little bit.
So you want to add dorsiflexion, get a symptom response before you add neural tension, because if this is already painful, you wouldn't be able to blame that on neural tension. So with what you feel right now, does anything change as we lift up?
Stretch. Oh, a big stretch right there.
Big stretch. Does
Stretch.
this affect your pain at all?
No.
No. Where's the stretch? Is that
Hamstring and back of my glute.
okay? Is that similar to this side?
Yeah, actually this one felt like it was tighter.
Okay.
Yeah.
And it didn't have any bearing on familiar symptoms,
Correct.
concordant symptoms. So now I'm going to look at the peroneal nerve. So what do you feel there?
Stretch.
Stretch.
Mhm.
Okay. So now we'll add sciatic tension on top of that. How does that feel?
Stretch. Stretch. Okay, that's
Okay. Is that affecting the foot at all?
no.
No.
Uh-uh.
Okay. All right. And then we can look at sural nerve just to be thorough.
Yeah. That's okay. Go.
And how are you doing here?
Ow. That hurt in the ankle. But it stretched in the calf back here too.
And that hurt in the ankle?
Yes.
Okay. Let's do it again just to be consistent and thorough. How are you doing here?
Okay.
That's okay. Is it affecting anything?
Mm-mm. No.
Looks like the knee maintains straight. Okay. All right. So no effect there. All right. Okay. So far we have looked at non-specific palpation for sensitivity. We've looked at observation of foot position, swelling, discoloration. We've looked at a couple of functional tests, just gait quality, squatting, single leg balance. We've looked at active range of motion, passive range of motion, end feel assessment. So we have not looked at special tests. So with an ankle sprain, a special test that we would be interested to look at would be the anterior drawer to look at stability and if there's any hypermobility in this area. So this would be a good idea where I'd want to look at the asymptomatic side just so I can have an appreciation of what normal feels like before testing the painful side. So all right, I'm going to have you scoot towards me so the feet just hang right off the edge of the table. That's good. And then I'm just going to stabilize the distal tibia and fibula. I'm going to cup the calcaneus, and then I'm going to pull from a posterior to anterior direction with my left arm that's under the calcaneus. And then we would repeat test on the other side, just for ease of observing. We're looking for symptom response. And I don't feel any laxity, and it doesn't reproduce any pain. So that would be a negative test. So the other component of the examination is the neuro exam. There's no numbness or tingling. There's no report of weakness. There's no muscle atrophy. So going through a neuro exam is now a therapist's choice. If you want to routinely do it on all patients, or if you want to selectively add that into your exam based on if it looks warranted. But we did look at a mobility assessment for the sciatic nerve, sural nerve, and peroneal nerve to look for sensitivity, which those tests were negative. So at this point in your exam, you need to start thinking about what your diagnostic thought process is when you've gone through those steps and looking at the meaning. This would be a time where you have baselines that you could use for reassessment, and you'd want to find something that you want to try to affect in the foot and then reassess baselines following. So now once your exam is done, you want to try to take whatever clue you have to make your best physical therapy-based diagnosis, and to try to confirm it or to learn more about it. We would want to take some baseline that was painful. We would want to try an intervention of some kind and then reassess your baseline. So the clue that I'm going to go off of is the pain during movement passively. Makes me think more about a joint pathology versus a soft tissue pathology, that we can move through the range of motion. It feels better as I stretch it further. Would kind of rule out stiffness and tensioning the tendon or ligaments. And so I'm curious about that pain during movement being suggestive of a joint. We did neural dynamic tests. Those are negative. There was some consideration of CRPS, but we don't have any other clues from an observation standpoint that would suggest that. And so we want to see if there's any undiagnosed joint pathology, joint mechanics problems that we can address. So in order to look at that further, we are going to start loading through a joint. And we can either choose to do that from an accessory standpoint or a physiologic standpoint. We can do patient-generated or therapist-generated. So we're going to choose to do a patient-generated repeated movement or physiologic mobilization. So let's go ahead and get you into kneeling with your right foot forward. So dorsiflexion was a movement that was painful. And we're going to have Katie do a physiologic mobilization. Go back to neutral. Perfect. So we're just looking to make sure we're looking at the arch. We're seeing if it can maintain good position. The heel stays on the ground and the knee is driving right over the toes. We have already done a set of this movement, which was creating a pain during movement. She would start to reach a pain, and as she pushed further into it, it almost felt a little better. So we've already done a set of this movement. Our key baseline was standing pain. Single leg stance was really difficult and painful. So we were using that as a first quick reassessment following this intervention. How's that feeling?
Doing okay. Yeah.
So when you do a physiologic mobilization, now we're looking to see, you do about 10 repetitions, you get a response. And if it's same or favorable, you would go through another set. You would add more repetitions and see if the improvement to the baseline increases or if it plateaus. Okay, let's go ahead and stand.
It actually feels like that calcaneus is moving better on that right side.
Okay. And then rechecking single leg balance and how it feels pain-wise.
No pain.
No pain?
No pain.
Okay. Okay, good. So that furthers the diagnosis where there is a rapid, significant change in pain and function. and that would support the diagnosis of a joint derangement. And that would lead to an intervention, so that test can become the treatment as we prescribe a physiologic mobilization for home. And that provides us now an opportunity to reassess on the next visit and see if we are getting on the right track, and then we could advance or modify intervention from there. This was also a key baseline that we had looked at, which was just laying supine with the knee bent, and the foot being in this position was really painful.
No
And
pain, no.
Currently there is
No pain.
no pain.
Mm-mm.
So that kind of confirms rapid, significant change,
Yeah.
consistent with a joint derangement. What's up, everybody? This is Ryan Beck with Complete PT Institute. Thank you for watching that history and exam, and I hope it was valuable to you. But I think what's really going to be valuable is the post-exam breakdown, where we look at the 4-tiered diagnostic process, and we look at the history, and we look at the exam, and a link into treatment, and see how it all ties together. One of the first important points to note in the history and in the exam is that there are other questions that could have been asked, there are other interventions that could have been done, and there were certain examination tests that could have also been done. When it comes to efficiency, the key is to cross a threshold of significance where we know that we have enough information to be safe and we have enough information to be effective in treatment. And that's what we see in this process. The first step being safety. When we look at her history and we see that it's 2.5 years old and she had a specific mechanism of injury. Prior to that, she had no previous pain. So just that alone tells us that this is probably not a systemic problem. This is an orthopedic problem. From a safety standpoint, an orthopedic problem could be a red flag if there was a fracture or there was something unstable and we shouldn't be moving this patient around. But she had appropriate imaging, and it's chronic. She has been living her life, hiking, walking, working, being on her feet all day, and there's pain. But certainly 2.5 years later, if there was a significant pathology and she has already had physical therapy, we would have already exposed that there was something more serious from an orthopedic standpoint going on. So it doesn't take much in this case to know that we're not dealing with a safety concern, a red flag concern. When it comes to the rest of the history, we learned that her pain is pretty non-specific in terms of how it comes on, meaning it's just general weight bearing. It's not necessarily a certain activity when she's in weight bearing or a specific movement. It's just the more time she's on her feet, the worse she feels. It is a gradual, progressive worsening as the day goes on. So when you think about her initial injury, which was a tear in a peroneal tendon and an avulsion, if we had to say, is that weight-bearing pain she's still currently feeling still related to that initial pathoanatomic label? Well, I suppose that's possible. But when we think about weight bearing, she's not stressing her foot into inversion, eversion. She's just placing weight through the foot as she walks around through the day. And so we would have to ask the question, 2.5 years later, is that tissue still pathological? Is that something that is the root cause of the problem? So as we consider that question, we would need to do more testing in the exam to either support or negate that idea. We have to think about that first tier diagnosis, which is inflammatory, systemic, mechanical, or neurological. Well, from the systemic standpoint, we already talked about how that doesn't make any sense, and we can kind of rule that out. The second category being inflammation, which in her situation, again, it's chronic. It's 2.5 years old. In the exam, there's no visible swelling or discoloration or heat or anything like that. And her symptoms totally reset every day as she just gets off the foot, goes through the night. If she was overdoing it during the day and inducing an inflammatory response, typically they do not feel better at night. Inflammation commonly upticks at night as the body attempts to heal. She's completely pain-free at night, does not wake her up at all. She wakes up in the morning, she's asymptomatic. So all those findings would suggest I don't think we're dealing with an inflammatory problem. And then we get to the nervous system component. She doesn't have any numbness or tingling. She doesn't report any discoloration, things that could suggest maybe CRPS, a muddled look to the foot. So we're going to do some testing of the nervous system to see in the exam. But at least at the moment, I don't really have any significant clues that would suggest that this might be a neurological problem. She didn't exhibit fear avoidance. She didn't have any affective components that I could perceive during the exam. And so we'll rule in or rule out a nervous system component later. But at the moment, from my history, I'm thinking that we have some kind of a mechanical problem that we need to test for. So when we think about tier 2 diagnosis and tier 3, we're thinking about location. Is this in soft tissue? Is this in joint? If it's in joint, which joint potentially? And then tier 3 classification would be what type of problem? If it's a soft tissue problem, is it contractile soft tissue? Is it articular soft tissue like a capsule, ligament, a stability tissue? If it's a joint problem, is it joint mechanics, joint motor control, joint derangement? These are terms that we'll talk more about as we get into the exam. And then tier 4 is why. How did she get to this point to begin with? So if I start with tier 4 for a moment, the first thing we looked at in the exam was observation. We did a foot posture index and we looked at the position of her foot, and we could see that she has a more supinated foot. If she has a more supinated foot, a high arch, and she injured her foot not doing something dynamic like jumping or cutting or a contact injury where she rolled her ankle, this was when she was walking. So it sounds like she's vulnerable to inversion sprains to begin with. So when it comes to tier 4, did she get into this circumstance? Well, we're going to want to address that in rehab by trying to soften that foot some if we can. Try to make that foot a little bit more of a dynamic, shock-absorbing foot where she's a little bit less supinated. So we could use mobilizations and exercises and things like that to try to affect the midfoot, the navicular bone. So that observation piece doesn't necessarily help me with my diagnosis because both feet look symmetrical. So it's not really going to give me diagnostic information about where's the pain coming from, but it definitely helps me in that tier 4 category. The next step is really where we get a lot of good information that we need to talk about, which is the active and passive physiologic movements that we tested. When we looked at the active motion, we saw that there was a loss in plantar flexion that reproduced concordant pain, but the other motions actively looked symmetrical. Now, when I added overpressure, this is probably the most important key to this entire exam. When she inverts her foot, when I do it passively and she's relaxed, I'm making sure that there's no muscle guarding, that she truly does feel relaxed. And as I take her into inversion, I'm wanting to see pain response. I'm wanting to see if I can appreciate an end feel. And I want to know, can I complete end range and equal to the other side? So as I do that, I approach pain. Now, it's very common for clinicians when they have their hands on a joint and they induce pain with movement that they want to stop. That there's some worry that if they go further, that might cause injury to the foot, or it might cause the patient to lose trust and feel like you're torturing them. But I informed the patient that if it's tolerable, I want to try to go a little further and explore what happens to that pain response if I go further. And lo and behold, as I took the foot further into the range of motion, we discover pain during movement, which means that you pass through pain. It hurts. As you go more, it feels better. Versus end range pain, which the further I would take it, the more it should hurt. End range pain would be expected if she had peroneal or ligamentous dysfunction of some kind, fibrosis, scarring, or still injured tissue that I'm tensioning. If that were true, she would not have pain during movement passively. She would have end range pain that gets progressively worse the more I tension those structures. So immediately from that test, I know that those pathologies have been ruled out. Now, the other thing that I can rule out is motor control, because she is passive. If she was actively moving with pain during movement, that could suggest a motor control. That maybe something about the muscular contractions moving a joint through range is faulty to some degree. But if this is passive, where the neuromuscular system is not at play, she's passive, and now I'm really just stressing the soft tissues, which I've ruled out. So it must be something going on with how the joint is moving. I like to think about a train and a train track. If they were just slightly incongruent, that's not going to be a smooth gliding articulation. When the train and the track are perfectly congruent, they'll just roll nicely along. And that's kind of what I'm looking at as I go through that pain during motion. Is there an articulation in the foot that is somehow disrupted? Or the alignment of car tires. If the car's veering off to one side because of imbalanced tires, we would need to change that. So sometimes that's called a joint derangement, joint dysfunction of some kind. There's different terminologies for this, but that's kind of where I'm thinking now. That would be tier 3 diagnosis, which is classification. What type of problem am I dealing with? To go back to tier 2, which is location, I could try to tease out, is this talocrural? Is it subtalar? Is it calcaneocuboid, talonavicular? What joint is this? Well, it's more on the lateral aspect of her foot. So I can start to think about joints that are more on the lateral aspect of the foot. And in the exam, what I didn't spend time doing was going through passive accessory tests of all those different articulations. The reason that I didn't do that is because one of my goals in the exam is to get to treatment and try to help the patient to get rapport. If I spent all of my treatment time or all of my appointment time on just getting all the diagnostic pieces as specific as I could, I would have run out of time and not had enough time for intervention. The patient would have left the clinic without good homework to do. So I made a judgment call to say, I think I know enough to move to the next step and start looking at a confirming test of a joint derangement. If I needed to tease out specifically which joint later, I could do that on subsequent visits, but I didn't feel that I needed that information today. To clear out the nervous system component, we wound up the sciatic, peroneal, and sural nerves, which were all negative. Equal range of motion, both sides, and it did not reproduce any of her familiar pain or concordant pain. She does have hyperalgesia. She does not have allodynia, but she has hyperalgesia in various spots. And that could suggest a neurological component, but without fear avoidance, without effective components, without numbness and tingling, without positive neural tension testing, it is certainly not my top priority to put that as my tier 1 neurological category as primary. That might be a secondary finding. And if I can treat the mechanical problem, that hyperalgesia might improve on its own. So now I just have that palpatory test in my back pocket to go back. I could use it as a baseline, but it is not enough to skew my thought process of my diagnosis. We checked a special test of an anterior jaw just to clear out any instability of the ligaments in the foot. That is a good special test. It's fairly well researched. A lot of the other special tests of the foot don't have a lot of research on them, but the anterior jaw is a good one. And that felt very firm, equal to the other side, did not reproduce symptoms, which is consistent with ruling out a soft tissue previously. So I'm at a spot now where I want to affect the articulations in the foot. So I could use an accessory load, I could use a physiologic load, I could use patient-generated, therapist-generated. And as I do that, I have baselines that I'm going to go back to retest. We looked at functional tests as well. We looked at a squat briefly. We looked at a single leg stance, and they both reproduce pain. So we could look further at the quality of the movement, but at the end of the day, I have a more primitive test that needs to be understood and cleared out before we go to a higher level of function. Now, some clinicians will start with functional movement, and if the movement is dysfunctional, then they'll work their way backwards and try to answer the question, why is that squat pattern dysfunctional? Whether you start with primitive tests and move your way up, or you start with functional tests and move your way back to figure out the underlying impairments that are resulting in poor functional movement patterns, either way, you can get to the same answer. We're just going to use those as a baseline reassessment potentially. I chose to use patient-generated forces because it allows the patient to be independent if it works. It gives her immediate homework that she can use on her own. If I use an accessory mobilization and it's effective, that's fine. But I now have to go and say, well, what exercise am I going to give this patient to use to maintain any benefit? So I choose to use patient-generated forces first. The patient's in control. If there's pain, they're managing their forces, and it leaves them independent. So that was my choice of using a patient-generated physiologic force. I chose weight-bearing because her problem is in weight-bearing. When she was doing the dorsiflexion movement in the treatment portion, exam treatment link portion, we had already done a set, and that first set really exhibited a pain during movement. She would lunge forward and feel some pain, and as she kept going, she passed through it. So now I've got two movements where she is reporting pain during motion. As she did a second set, she could lunge back and forth through the movement, and there wasn't pain during movement. We reassessed single leg stance, and in between videos, which I didn't capture, but she reported in between videos that when she lays down on her back with her knees bent and her foot's in plantar flexion, she can't stay in that position because it's too painful. So we used that as a baseline as well, which you could see was abolished after two sets of a physiologic mobilization into dorsiflexion. When we see a rapid and a significant change to the patient's baselines, we can now confirm that there was some kind of a joint derangement, joint mechanics problem that is positively affected by that intervention. Some might argue that there's a neurophysiologic phenomenon that could occur there, and I don't argue that. But what we really need to see next is the lasting component. If there is rapid and significant, we also need to see lasting change. That's what visit number 2 is for. I like to tell the patient that this is like playing a game of chess. If my opponent are the symptoms and I'm on this side of the board, I look at the board, and based on what the board looks like, I'm going to decide to move a piece. Today, the piece I moved was a physiologic mobilization. Then I'm going to look at the opponent and I'm going to see, did I gain an advantage over my opponent? If the opponent takes my bait and moves in a position where I am now gaining advantage, the patient's getting better, things are improving. When they come back the next time, that's when I can see what the opponent really has done. If they come back and they're improved, great. I'm going to know what next piece of that puzzle or that next chess piece that I'm going to move. Once I have the motions and the pain and those more primitive baselines managed well, now I can shift gears towards prevention. So we start to see this examination to diagnosis to treatment to outcome and then prevention. I want to work on that highly supinated foot. Make it a little more supple. Look at balance a little bit more specifically. So I hope going through that diagnostic process and into a treatment link was helpful. As you master those steps in the exam and you learn how to interpret each of those master steps, it will be extremely powerful in getting to a diagnosis and an effective treatment rapidly. And it keeps the patient in control if they're able to generate the right type of exercise and force to self-manage their problem. So I hope you enjoyed this video and look forward to sharing more with you soon. Thanks a lot.